So as we can see there, I'm not going to read the top one because I think it's a little bit wordy. I think the bottom description there gives me a much better understanding. Pain is whatever the experiencing person says it is, existing whenever he, she says it does. I'm not going to discuss patients with medication-seeking behaviour. So those patients that turn up to ED and say they've got a really bad back or they've got this and that because they're seeking an opioid medication, which unfortunately does happen. The reason I'm not going to discuss that is because I think it really blurs the lines of us being able to do a pain assessment. So for the point of this lecture, I want you to think whenever anyone says that they've got pain, they have pain. When you go into the real world and you experience those patients, I'll let you discuss with your buddy RN of how you discriminate between the two, how you treat the two. But for this lecture, if you tell me you have pain, then you do. So the types of pain that we're going to be discussing, so I think the first two are pretty self-explanatory. So acute and chronic pain, and we're going to look at these in a little bit more detail. I just realised today that I've been pronouncing this one wrong for 5 years. So I was always saying nociceptive, but apparently it's nociceptive. So burning yourself is an example of a nociceptive pain. So basically any physical injury that you have. So acute pain, so if we think of acute pain when we first experience pain because we burnt ourselves on the stove, it serves as a purpose. It serves as a purpose that we, as a person, immediately do something to remove ourselves, if we can, from that pain. So obviously if we put our hand on the stove, we realise that's painful, we remove our hand. If we don't do anything, so I'm going to hark back to ED because that's where most people would go initially when we're in pain. We've broken our arm or we've broken our leg. We're going to go into ED. If we don't do something quickly about that pain and we don't have an appropriate pain management in place, then that pain does have the potential to have systematic complications and threaten their recovery. As you've seen on the QADS form, pain is at the bottom. It's one of those observations that always gets missed. And we'll talk about that later because normally we only ask about people's pain if we think someone's in pain. If we can't see that someone is in pain, if they're not giving us some observations that, I'm actually sore here, we often don't ask that one. But what we should be doing, and again when we talk about the elderly, we should always be making sure that that is our routine observations. Even if they say, no, it's fine, stop asking me, what's the harm in asking, are you in any pain once an hour? So chronic pain, the big difference here is that it doesn't serve any biological purpose. We've had that acute pain, we've moved our hand from the fire, now we've got chronic pain, which has been going on for years, 2 years, it's not doing anything. This is obviously going to have, if you imagine that you're in constant pain all the time, this is going to have massive implications, not just you, your healing and your sense of health, but things like employment, being able to perform activities of daily living, going to school. Could you imagine study for an assignment if you're in constant pain that you can't relieve? But if you're on a ward that the pain team come around quite often, please feel free to say to your buddy nurse, any way that you can get me a day with them to spend, because the pain team's really good and you'll get lots of information. You'll get lots of information on how they're treating different pain, what type of management plans they're putting in. So nociceptive pain, we've already mentioned, so it is basically any physical pain that we come in contact with. So it's we've burnt ourselves, we've stabbed ourselves, we have broken a bone. So anything physical, and obviously that would normally fit within the acute pain as well. Anything physical, and the reason that it's nociceptive is because the nociceptors are within the skin, muscle and skeletal structures. So they're the first things that will tell us if something has damaged those things. Hence why we call it nociceptive pain. And it does imply that there is going to be damage to some somatic or visceral tissues. So basically when we're talking about nociceptive pain, we're normally talking about acute pain because something has immediately happened, something is damaged, and our receptors have picked something up. So neuropathic pain, so some of these, so diabetes, herpes zoster, so shingles. So if you've had shingles, shingles will basically be the condition that you have after chickenpox. You've had chickenpox, you thought you were over it, you're never going to have it again, and then all of a sudden you come down with shingles. And shingles follows your nerve pathway. And then when you're healed and you're away from those shingles, you've unfortunately still got damage to those nerves. You're going to be in neuropathic pain, and unfortunately neuropathic pain is quite difficult to treat, and we'll discuss that in a moment. You might also, this is a little bit more rarer, to have surgery and have issues. You'll find that phantom limb pain that you might have heard of would be considered a neuropathic pain. So the physiology of pain, I'm not going to worry about too much of this because there's a picture afterwards. Now, if we have a look at this one, now, the reason I think this is a good one, because we can see the different types of, I mean, we're moving obviously away from Panadol, but different types of pain relief that we can have. So we can see here that a local anaesthetic or a general anaesthetic would start right here. So when we actually feel that noxious stimuli, so if we burn ourselves, we're actually stopping anything from being felt at the start. An epidural, for example, is going to stop that transmission of the pain. And then the systemic opioids is stopping the transmission to the brain. That's quite important because when we talk about opioids, especially, we normally always talk about things like respiratory depression, because we're basically depressing our brain from doing its normal thing. So if we know that systemic opioids work here in the brain, we know that there's going to possibly be some side effects that are probably a little bit more serious than if we're giving Panadol. Now this one here, the gate control theory of pain, so the A delta and the C fibers, and that's where pain will transmit into our brain. If we know that pain goes up the small one, touch goes up the large fibers. Now basically, to put this in a nutshell, and like I've said many times, I'm not a scientist, so I'm going to give you my very basic pediatric explanation. Who has ever stubbed their toe, and then as soon as they've stubbed it on the bed, they step on it? Who has ever had a horrible headache for the whole day and has gone to get a massage? What's basically happening is the theory states that basically only one of these can be open at a time. So if the pain is more than the touch, then the pain is what's going to be transmitted up to the brain, and that's what I'm going to feel. If, however, what's happening in these large fibers, so if that touch sensation exceeds that pain sensation, then I'm going to close the gate off to here, and it's going to be that touch that I feel that goes up to the brain. Hence why if we bang our arm and we rub our arm and we try and make that feel a bit better, that's basically what the theory is suggesting, that if we have pain, we try and do something about that. We might stand on our toe, we might rub our arm. We're trying to close off that gate to these small fibers and try and increase that touch sensation that's going up the large fibers. Now the problem is this only really deals with how pain is transmitted, the theory of how pain is transmitted to the brain. It doesn't really talk about us as individuals. We might experience pain very differently, and that's where the biopsychosocial model of pain comes in. So we can see here that nociception is at the very base of that. So the actual acute pain is in the middle. How we appraise that pain is based on a very individual. So how we know what that pain is like. Now, if I use, for example, myself and a 1-year-old. Now, if we stub our toe, I know that's not the worst pain I've ever been in because I can appraise it and I can appraise it against previous experience. A 1-year-old, that might be the first time they've ever been in pain. So for them, that is the worst pain they've ever had, even though the injury, the damage was exactly the same to us. So the pain behavior, so you might see with some people, again, they might have had the same injury, but you might have some people rolling around on the floor, clutching their stomach, they're in the worst pain ever, but some people can sit there quite stoic, quite happy, or they appear more than happy. A pain behavior for a woman going through labour, now they know it's going to hurt, but they get through it. But I reckon, put me through labour, I'm going to behave very differently to that. Because it's not something that's in my world. It's not something I've ever thought of. So how we behave to pain is also very different based on what we think that pain is or how we should go through that pain. And then that's social roles for pain and illness. I used to do this. There was a great ad, I think it was like 2 years ago, and they were basically, it was trying to get through to younger generations about sexism. And there was a boy and girl throwing a ball, and the boy threw it, and the dad said, "Oh, you throw like a girl." But he was throwing to a girl, and the girl was stood there going, "Oh, thanks, what, I can't throw." Now, until I watched that, I was like, oh my God, I've been completely sexist without thinking, because I would say, the first thing I would say to my son, if he stubbed his toe, he hurt himself, or he's come off his bike, oh, don't be such a girl. Until my wife pulled me up on it. Now, my wife is much scarier than I, and I know that if we both fell off the bike, she would be the one who would kind of get up and brush it off. I'd be lying on the floor, oh, I've broken a leg. But without even thinking, I kind of put a social role on him. I said that you're a boy, you should be able to deal with this. Hence why I'm very glad that I don't have a girl, because a girl would probably be able to wrap me around their finger and do whatever they wanted. But we put social roles on people, a bit like when we say boys should play with cars and girls should play with a Barbie. We put that on how people should interact with pain and illness as well. This is the difficult thing about us observing pain. We often only assess, we often only ask people about their pain if we think we can observe something. If we think that they are outwardly expressing something that we think we would do, that's the only time we often assess them. It could, however, be that because of their culture, their experience, that they're not actually expressing how we would, because obviously every individual is very unique in how they experience these things. So how we experience pain, how we express pain is going to be very different, and we should never judge based on how we should do that, because we're going to always miss things if we think our way of the world is the correct way. If we think about age, if we think about the two extremes, the really old, the really young, they're probably going to be the two demographics that can't really express themselves very well. Now, I am tarring a brush there with old people. I'm not saying all old people can't express themselves, but I am thinking of, with increased age does unfortunately come increased conditions such as Alzheimer's, dementia, so those conditions that people aren't able to express themselves. Obviously, a 6-month-old in pain, all they can do is cry, and it's up to the parent to know, have they just pooed themselves or are they actually in any pain? Whilst we might put a gender kind of social role on people, it is proven that males and females do experience pain very differently. Apparently, women have a much higher sensitivity to pain, but they react very differently to pain. They're able to take a lot more pain on, which would kind of make sense since you guys have got to push a baby out. If you weren't able to tolerate a lot of pain, then the human race would be extinct quite quickly. If you look at males and females who experience chest pain, females will often express very different things. So if we think of chest pain and a myocardial infarction, we normally think of a crushing pain, a vice-like pain, like an elephant is sat on the chest, that women come in and they say, oh, the pain, oh, it just feels a bit uncomfortable. And they say, oh, how long have you had this pain for? Like men, it's normally, I've had this for an hour and I'm really worried. And the women are like, oh no, I've had this pain since when I got up, but I had to take the kids to school, and then I had to do the washing, and then I had to do this, and then they kind of toddle in, and they're actually in a much worse condition. So again, just because someone experiences or they say something different, they explain something different, doesn't mean that there's not anything underlying the same. So culture, and I suppose culture goes with the meaning of pain, because various cultures might associate pain with something. It might be, well, you've got to go through this pain, or this pain means this, and therefore you need to just ride it out and you need to go with it. So therefore we attach different meanings of pain. So unfortunately, pain often does increase anxiety depending on how that pain is caused. So again, if I have chest pain, I'm going to become really anxious because I don't know if any of you have noticed, but I'm a bit chubby. And therefore, I'm probably going to think that chest pain, I'm having a heart attack. So the pain is going to increase anxiety, but anxiety is also going to increase the pain as well. So unfortunately, you've got that vicious cycle. So sometimes before we do anything about the pain, sometimes we actually need to treat the patient, get them to calm down, talk to them before we can actually, because otherwise, Panadol and Nurofen is not going to do anything. You can throw them Panadol and Nurofen, but if they're in the room kind of climbing up the walls because they think they're about to die, that medication is not going to do anything at all. Coping styles and family support. So how we cope with pain is going to be very different, and how we want our families and our social support is also going to be very different. So again, please remember that when you're in the hospital setting, just because family and friends are there doesn't mean that the patient wants to see them. So please make sure you're always checking in with your patient, especially if your patient has come in, they've just broken an arm. They just might want to convalesce in the bed for an hour on their own because they're a bit embarrassed. Always check in with your patient. Do you actually want your family and friends to come in, or shall I just park them out in triage for a little while? The one thing I'm going to mention here is it needs to include the patient's quality of life. So it can't just be that we are giving the maximum dose of something to knock out that pain. What happens if I've got a truck driver and he's got chronic pain, and normally that chronic pain I would treat with morphine? Do I want to send a truck driver with a crap load of morphine out on the roads? So I need to think about their quality of life, but also what their lifestyle is as well. I can't just treat every pain exactly the same. I've got to tailor that to the individual. We should be taking any reports of pain seriously. It's not our job to be the judge on who should get medication, who shouldn't get medication. If, however, you're ever unsure or you think, they're telling me 10, but I really aren't sure about that, go and speak to your buddy nurse, go and speak to your TL, or go and speak to the doctor. Your job is to record that 10 out of 10, and your job is to respond to that 10 out of 10. You can then kind of escalate your concerns, but your concerns aren't something that you should base your care on. This one here, as you can see, the P stands for provoking or palliative. So provoking is what causes, what starts that pain. Palliative is, well, what is it? What things can be done to make that pain better? So we often will say, well, what's the region? Can you point to where it is? With some people, you need to be really specific. With one finger, can you point to where it is? Because a lot of the time you say, well, can you point to where it's sore? And they'll go. Now that covers, especially if that's a female, that covers a lot of organs underneath. So if you can get them to be as specific as possible, get them to point exactly where it is. The other thing that's on there is, where does it radiate to? That can sometimes be important for things like appendicitis pain. With right iliac fossa pain is if I come in with appendix. Now, as well as having the right iliac fossa pain, because sometimes, especially in boys, that can signify testicular torsion. Now, if anyone doesn't know what that was, that's basically when the testes kind of twist around on themselves. And if you don't sort that out, basically one of your testicles will die off because it's not getting enough oxygen. But if you press on the left side, and they're thinking, what are you doing? I told you it was on the right side, but then let go really quickly, they get a rebound tenderness. And so sometimes the radiating pain can often tell us a little bit more information about where the pain is actually located. Clients understanding this is important, however, sometimes less important in the age of Wikipedia and Google, because some people will come in with these really, really fancy things. Someone that came into ED and was demanding seeing a surgeon because I need to see someone about my ovaries. So sometimes the client's understanding is great, but if they've spent an hour looking on Wikipedia, they can come up with everything. The time and onset of duration, that's normally, I mean, if we're thinking about chest pain and MIs, that's obviously going to be important to know, because the quicker we can act on that and how long someone has had an MI is going to impact on not just the pain management you're giving them, but what other nursing interventions you're going to do. Now, for kids, this might be quite difficult. If we go back to that 1-year-old, the first time he stubbed his toe, and I say, oh, can you tell me from 0 to 10? Well, firstly, that 1-year-old doesn't have a clue what 0 to 10 means. And also, if they've never had pain, how do they really link that one? We can use the faces one under here. There is, however, a problem with all of these. If we don't have anything to kind of measure it against, we're normally always going to say 10. I would always describe it as, so if 0 was sat on the beach and 10 is you've just thrown through a car window and your leg is snapped off. Clearly that was with teenagers. I wasn't using that on 5-year-olds. That would normally work because they would go, okay, I know what a 10 is. And also, if they told me 10, I would say, okay, well, that's fine. I'll write down 10. So does that mean I can cut your leg off and you won't feel any more pain? Oh, okay, maybe a 3. So sometimes you might have these, but you need to explain them. This one down here, the faces one, I mean, that looks pretty self-explanatory using on a kid. A lot of kids will come in and they're crying, so they might pick at the 10 face because they're like, well, I'm crying, therefore it must be 10. Some kids, however, pick the face they like. And they go, well, I'm in lots of pain and my arm is dangling here, but oh, look how happy he is, so I'm in no pain whatsoever. So sometimes, again, you need to explain these things and you need to say, well, this is you when you're nice and happy, but you look a little bit sad. Which face would you be? Now, we've mentioned very briefly pain in older adults. I don't want to say that everyone, just because they get old, is in pain. But there are going to be lots of people because of chronic conditions, because of illness, because things start to deteriorate, that there is going to be lots of pain. The problem being with older people in pain, they are normally the people notorious for really not telling you their pain. And a lot of the time you will ask them and they'll say, oh, I didn't want to be a bother. I saw that you were really busy, so I didn't want to ask for any Panadol. Hence why it's really, really good to get into practice when you're doing your QADs, when you're doing your rounding, when you're talking to your patients, always ask them, how are you feeling today? Any pain? Because a lot of the time they're not gonna give you that information. They're gonna look at you, you're running around like a headless chook, and they're not gonna tell you their pain score. So please make sure you preempt that and ask them and don't wait for them to tell you. When we talk about cognitively impaired persons, I'm not just talking about people with global developmental delay or maybe people with Down syndrome or anything like that. I mean, yes, they would fall under that category, but for me, I could put kids in there, I could put a 6-month-old. Okay, they're not impaired, but they're not cognitively able to tell me about their pain. This pain ad, this is for people with dementia. So there's going to be lots of conditions that are going to impinge someone telling you and giving you a number, oh, I'm a 10 on this score, or I'm that face. So there are, again, lots of different tools you can use. The pain ad is this one here, and you can see that it's something that you as a nurse would use to give a subjective pain score for your patient. So you would have a look and you would go and say, okay, well, they're breathing normally, so they're a 0. They're not vocalizing, so they're a 0. They do look a bit frightened, so I'm going to give them a 1. And then at the end, you would tot up your score and you'd be able to get a score out of 10. So planning, so we've assessed someone, we know they're in pain, they've told us they're in pain, we've gone through our PQRST mnemonic. We need to start planning for that person. We need to take into account the individual. I might have to get the pain team involved depending on what kind of pain it is. If this is a chronic neuropathic pain, then obviously this isn't something that can just be looked at by a GP. There needs to be a whole team approach in here. Now, this is the World Health Organization's pain ladder. It was initially developed in the 90s purely as cancer pain treatment, but now they've extended it to look at all different types of pain. As the first step on the ladder, we would give a non-opioid, so we might just give Panadol and Nurofen, and we might give an adjuvant medication as well. So an adjuvant medication is basically a medication or a pain medication that isn't designed for pain relief, but as a side effect, it does have pain-relieving properties. For example, antidepressants. Now, when we talk about adjuvants, we're not giving the same dose that you would to treat the thing. So an antidepressant you could use as pain relief for neuropathic pain, but it would be a much lower dose. The problem with pain and pain relief, a lot of the adjuvants, they have no idea how it works. So like anti-seizure medication can sometimes be given. They have no idea how that helps, but they give it because they found out as a side effect, it helps with certain pain. At the bottom, we've got the adjuvants, non-opioids. Again, I'm going up here. I might be giving opioids. So commonly, we would normally give something with codeine because it's kind of that really mild opioid. Not that you can get it over the counter now, but a mild opioid for me would be a codeine-based something. And then if that's not working, if the pain's persisting, then we would go up to something, an opioid. A classic opioid would be morphine that we might go to. Depending on what we think the pain is, the cause of the pain, we might jump up to number 3 straight away. This is really just a stepped approach. If someone comes in with what seems simple pain, that we start on number 1 and then we work our way up the ladder. We don't always go straight for the morphine straight away because that would, in a lot of cases, be inappropriate. Pain management. Distraction and music are often really good, especially in certain settings. And I know, I'm sorry, I'm going back to pediatric settings. There's always going to be a box with distraction stuff in. And the best distraction when you've got to do something to a child, and by that I mean that you've got to maybe suture something or you've got to put a cannula in, is a Where's Wally book. Because mum can lean over the child with the book open and kind of, cover up their face. They can look for Wally while everyone's kind of popping a cannula in. Music is really good. You'll find that a lot of places that might have CTs or MRIs will have, you can go in and you can request whatever music you want. So a TENS machine, a lot of pregnant women like a TENS machine and they put it on their back and it contracts and relaxes the muscles. We've already mentioned these. So we mentioned non-opioids, your classic, like I've said, Panadol, Nurofen. Opioids, your classic morphine. Adjuvants we've mentioned, and there's a slide in a second. Patient-controlled analgesia. So some patients will purely have a syringe. So it might be, normally it's morphine in there again, or it could be some other concoction. It's normally made up by an anaesthetist who then comes and it's in a locked syringe driver. Some patients, it's purely if they need something because they're in pain, they will hit the button. Sometimes, which is a little bit more common, is that the syringe driver will give a background infusion, a really low dose to kind of just kind of trickle in there, and if the patient needs a top-up of that medication, they'll hit the button. The machines are also, they've got a lockout, so you can't press it more than once in 2-5 minutes, whatever the doctor wants, because obviously you could kind of just sit there hitting it and then overdose yourself when no one's coming in to see you. So if your patient is ever on one of those, you should never be touching, even if your patient says, can you? And the family also need to be educated. This is not family-controlled analgesia. This is for the patient. It stays within the patient's bed. You don't hook it up on the oxygen behind the bed because the patient can't get it. It goes in the patient's bed. The family don't touch it. You as a nurse don't touch it. Physios, doctors, just for the patient. The one that I'm going to concentrate on is your opioids. So your morphine. Now, if we're giving it and we know where it works, we know it works in the brain and it does have some side effects, it depresses my respiratory function, I know that there is possible that I'm going to have a sleep apnea, I'm going to have opioid overdose. I mean, opioid tolerance is going to be that you're on it for a long, long, long time. You might be a cancer patient and you've been given OxyContin or something at home and it's now not doing its thing. But within the acute setting, we've got to be very careful that if we're giving someone an opioid, especially for the first time, that we are really monitoring their SATs, their respiration, and we're doing that quite often depending on what the hospital policy is. So if you've got asthma, things to avoid would be your NSAID, so your ibuprofen, because that can cause bronchospasms. Before we give that pain medication, we need to assess our patient as a whole, not just our patient's pain, but we need to say, right, I can see you're in pain, can you tell me, do you have any other history? Because the last thing we want to do, someone's come in, they've broken a finger, and we go, okay, here's some Nurofen, and all of a sudden they're now in respiratory distress because they had asthma and we didn't ask. Adjuvants we've already mentioned. Ketamine is actually one that we use quite often in kids for certain procedures. So a horse tranquilizer, and we often give it to kids for procedures. So antidepressants can be used in neuropathic pain. Like I said before though, we're not using them in the same dose. We're not using an antidepressant the same as if I have depression. We're using them in really small doses because we're not treating the depression, we're using it as that side effect. This is obviously where the WHO pain ladder initially came in. This is going to be something, a lot of, if you're on oncology wards, they will have lots of input from the pain team. They will have lots of case management conferences where they all speak and they all get the team together, and the pain management will be a really key one in there because we don't want to keep people at home all the time. Radiotherapy, they can come back in and out, but they need to be appropriately treated at home. But they also need to make sure that they've got the education that if something goes wrong because we're giving them high doses of opioids, that they know how to deal with those things as well. The few that I'm going to mention on here, so if we think of that we're in pain, we're unrelieved, we're now got the likelihood that we're going to develop chronic pain, the kind of things that we might start developing. So if we think of cardiovascular system, when we're in pain, our heart beats a lot faster, we have poor cardiac output, we have increased demand for O2 need. So just by being in pain, we've increased a lot of other things that might go on to develop different conditions, different illnesses. If we look at the respiratory system, I might start to breathe a lot shallower because it's a bit too painful to breathe deeply. I might get atelectasis in my lung. Some of my lung might start to collapse a little bit because I'm not using it properly. And then I've got all these respiratory issues following that pain purely because I'm not being able to breathe properly. The immune system, unrelieved pain will hamper your body's ability to have an appropriate immune defense. So you'll find that a lot of people in acute pain or chronic pain will often get lots of other illnesses. They will get, they will catch colds and little things like that because their immune system isn't working as appropriately as it should. Obviously, in some cultures, it's actually going to be what we consider the complementary therapies are going to be their kind of plan A. And it's actually going to be the Western therapies that are going to be complementary to those.